All right, we can start. Hi, everyone. Good afternoon. I think the last 2 days have been super exciting. Thanks to Society of Robotic Surgeries for giving us the opportunity to take you guys through an immersive experience of how to set up a virtual fellowship and everything else to do with the training of healthcare professionals. I am an engineer by profession. Worked in the virtual reality or immersive reality space for the last 2 decades. And I'm going to walk you through the future of surgical education with Dr. Rooma Sinha, who's also the chairman of the Indian Gynecology Robotic Association and also a practicing OBGYN robotic surgeon at Apollo Hospitals. Okay. All right. So I'm the CEO and co-founder of 8chili. We are a virtual reality company that's focusing on immersive training experiences, making learning more fun and engaging like never before. I think that's the core heart of everything that we do in this space on the immersiveness. We've also been covered recently by Gartner as one of the top emerging tech companies, especially working in the metaverse space. In the last 2 years, since we've been founded in the pandemic, we're a pandemic baby, if I have to say that. And I think it forced us to look at how to do training in much better ways. We've been working with some of the leading innovative companies and enterprises in this space, Mayo Clinic, University of Arizona, Apollo Hospitals. And I think we continue to do great work. And we've been publishing quite a lot of results on the efficacy of virtual reality for surgical training. So this is a really nice article. I was born after the internet, but I think definitely the metaverse is something that we all have our own views of. One thing that clearly stands out is it's a communication protocol that is spatially aware and understanding of the space that is around us. And when it comes about robotic surgeries, I think it's all about 3D and the spatial awareness that we have. So the whole concept of training using VR is very appropriate when it comes about training for minimally invasive or robotic surgeons. So coming to spatial computing. So the 2 things that are very important to us as human beings, we love stories, we love good movies, we love games. I think this continues throughout our life. So what doesn't change is when as we grow old, even when you're born as kids, we are attached to these 2 things. And I think the concept goes to if we gamify something, the intention or the message is super clear, it stays for longer, the recall is higher. A good story is always important, and that's basically how the game is structured as well. A 2-way communication. So if you are doing a lecture or a case-based discussion, and if you are able to communicate with your residents and fellows, I think that again brings in the neuroreceptors to reinforce what's being learned. Immersion is something that's come up with virtual reality. Interaction you always had with your desktops, laptops, and mobile phones as well. So with that premise, I think that's how the virtual reality and the future of immersive learning is going to be structured. The market is massive. People quote all kinds of numbers, but I think the biggest bet that came out was Apple launching Apple Vision Pro and Vision OS. This was just a couple of months back. And I think we have about 70 million virtual reality headsets in the market. And training is by far the 2nd largest use case after gaming, of course. So there are about 500 plus peer-reviewed papers on the efficacy of virtual reality for training healthcare professionals. It can be nurses, clinicians, surgeons, and allied healthcare professionals as well. Sorry. Right. So coming to VR simulation in training, there are a lot of studies that have been benchmarking some of the clear outcomes. One is the fast track way of looking at how much time it takes to learn and grasp a concept in VR. It takes about 80% lesser time. But it also increases your procedural understanding and accuracy by up to 50%, and also increases confidence by up to 60% as well. We've done a very large randomized control trial, double-blinded RCT last year across 3 locations, wherein we trained nurses, about 262 nurses, going through traditional way of learning and, of course, VR. And these are some of the results that we're going to be publishing in the Association of Nursing Studies as well. Eliminating the risk, because procedurally, when you're looking at complications or case-based discussions, I think those things can come to life in VR, and you are kind of like not just looking at a desktop screen or or your phone, preparing for a case. This is far better than that, because we are living in a world of vertical scrolling and attention economy. So when you put on a VR headset, even if your phone beeps, you probably are not going to look at it, unless otherwise you really have to, but the focus comes back. Reducing cost, so I think that's one of the important things. If you look at the intuitive consoles, a secondary console costs almost some hundreds to $500,000. So if you have to look at democratizing access to getting robotic surgeons or making robotic surgeons ubiquitous, so you need to be able to train them in a more cost-effective manner. The headset that you're looking at is about $300. So let's say if we can bundle this thing with an Intuitive or any of the other robotic platforms, then we are kind of talking about more surgeons who are becoming minimally invasive surgeons, looking at robotic surgeons, and of course increasing the value to the patients through these procedures. Right. So I listened to Fred's talk at LSI. He was talking about OR being a black box, and how when he started, there were so many things that will happen in the OR and it doesn't come out, and how Intuitive system basically captures so much of whatever you're doing, and it's available after the surgery for you to go in and look at what has been done, how things could be done better, and quantitative way of measuring things. I think that's something super important with the digital technologies that are coming in with the robotic systems. I think the challenges that kind of stand out in the robotics training system is expensive. I mean, it's super expensive to get people to get trained on being a robotic surgeon, having access to these consoles, answering the questions about ROI, why do we need a secondary console, why do we have to place it, getting people to train on these consoles, when there is off time, and the cadaver cost as well. So when we try to plug virtual reality in, we're not trying to take away the hands-on experience. It's not the only mode of training, but it's going to augment the way we are going to bring the experience to life, especially on the procedural side of things. I'm gonna run this slide because we're running short of time. One thing I want to bring out, is the visual haptics, what we see and look at, and when we start looking at things, we kind of train better as well, rather than just, working. So this is from Usain Bolt. Most of the athletes train by watching other athletes as well. That's also a way of training, and I think that's really applicable to the robotic surgeons as well. So this is the last slide that I have. I want to talk about the digital operating room. So there are a lot of companies who are working on capturing the procedures, quantifying them, bringing in AI-based, networks to assess and look at how the procedures are done. Now, if you look at the digital OR, the future of operating room will be AI, virtual reality, and of course, this whole thing becomes a digital OR as well. So the line that you see here in between, that's the immersive experience line. So we're building a platform that basically plugs everything that's happening on the digital OR and bringing it into the immersive experience side. The top portion is case-based discussions, visual haptics, spatial awareness. That's what robotic surgeons are really good at, looking at and doing procedures. And we also want to look at behaviors, engaging, emotion, and competency as well. So when we put these things together, we kind of get the training metadata that helps us build a better system with real-time training, proctoring. I think these are the first steps towards doing telesurgery. Before telesurgery, you can always look at being able to do teleproctoring or even training as well. That's it, and I cannot explain the experience, and that's why we have Dr. Rooma Sinha here. So if the panelists are all ready, would love to we are ready to cast? Okay.
Yeah. Yes. Thank you, Aravind. I'm Dr. Rooma Sinha, and I'm from Hyderabad, India, working with 8chili and Aravind and his team on this project for some time now. Right. So just to bring...
Just 1 second.
Yeah, sure. I need to start casting?
Yeah, I'll do that. Can I have your attention?
Sure. All right. While Mr. Navneet is actually doing a casting so that you can see on the screen what the others are experiencing on their VR set, this technology brought me closer to the fact that as a robotic surgeon, we do our surgeries in 3D, but we teach our fellows, residents, and colleagues in a 2D screen. Is that good?
1 second.
All right. So what made me believe that the surgeries that are being performed in 3D, if we can actually teach them also. Do you want to cast?
Are the panelists able to see?
Yep.
Okay.
Okay. So we'll just begin. As the lecture is just sinking for a second, I think all of you can see that what we start off is like a classroom. So it's like a board where we can talk about. So in this surgical tutorial that I have been working on with, I realized that it's not just to teach the surgery, but also to do the pre-planning. So we'll take you through one case of a multiple fibroid uterus, which you can see we have uploaded the DICOM images, and this can be used to teach students exactly how do you plan your surgery. So we can go ahead, look at various sections of the scan, make a plan, and really understand how to progress with the surgery. The other thing what we have additionally added to it is actually a 3D model. Now, if you can see, this is a 3D model of the same patient, which has now been created with using MMS software and is being used to understand the locations of all the fibroids that we will probably be excising. And the most important thing to remember and to learn is where is my endometrial cavity, because that's something I don't want to actually come in my way when I'm operating. So putting that across, once we do this part of pre-procedure planning, we can then take the surgeons or the residents and fellows with the surgical clip and give them a real-time 3D understanding as to where are the locations of these fibroids to be able to plan their surgery well, make minimal incisions, progress with the surgery, and remove all the fibroids, because we all do understand that any surgery, especially in fibroids in infertile patients, is the residual problem of residual disease. And of course, making minimal incisions, and that is the largest fibroid that we had in this particular patient. Other than the 3D planning, I'd like to take you through two small clips of the patients of endometriosis. And that's again a very difficult surgery for most gynecologists to perform. So this is a dissection in the right pelvic wall where you can see the ureter is being dissected off the uterosacral or the peritoneal nodule, which you can understand from, we can point a pen here where we can actually go and really understand where exactly this particular nodule is. Teaching to the fellows how to prevent a ureteric injury, how to use your scissor and fire it at the right point to get the disease out is probably going to be very, very useful in this 3D technology, that they can really understand what the surgeon at the console is seeing and doing. Taking you to just another one small clip in this particular patient, again another endometriosis surgery, where when we do cystectomy for an endometrioma, preserving the normal follicular tissue is the prime most important function that we need to perform. So this technology can teach students and can teach the fellow surgeons as to how to go fiber by fiber, dissecting the endometrioma capsule away from the normal ovarian tissue so that the least amount of damage that takes place in these particular patients. So this is just a very, very small examples of what we could do or what we are planning to do in this teaching space of robotic surgery in the population which is wanting to learn this technology so eagerly. So thank you very much for this attention. I am thankful to SRS, Dr. Patel and Dr. Martin for giving us this opportunity. Thank you very much.
Thanks, Dr. Patel.
I can take any question. I can take any questions if there are any.
Thank you. Any questions?
I think it's amazing technology. So can you be sitting in India and teaching in Australia with this?
I suppose we can. That's what we are thinking of, scaling up online. And so that if we put it up on a platform and somebody has a headset somewhere else, they can always log in and learn this in the 3D format.
So do we need a building for medical school anymore? I mean, all the students can be home and have this device and you can run a medical school from home.
A lot of work from home, teaching from home is anyway going on, I think, post-COVID.
Yeah.
But I think for the surgical teaching, and as I said, all of us are robotic surgeons, we operate on 3D, but we very rarely have our residents and fellows in the OT following us in the 3D format. So the another application which I think could be is having these headsets in the OT connected to the console, and while we are operating, 5 of them can actually see in the 3D and in their virtual space and understand that exactly what you're doing, where you're dissecting, where are your nerves, and then they learn how to prevent the injury to them as well.
I think the importance is tele-robotic, remote proctoring.
Yes.
And this can be
Yes,
just...
yes.
So let's say WIP has about like 5 residents. So if WIP wants 100 residents, I mean, like that can be possible. He can't accommodate 100 probably at GRI, but he can ship 100 Oculus headsets and everybody can have it. I think that will increase the ubiquity of how many robotic surgeons we will have per person or per patient population. I think that's definitely possible on the economics of scale, on the pricing side of things. And yeah, I think that's like one of the biggest advantages of VR.
Right.
Advantages of VR.
Right.
So clearly, excuse me, you'd have narration and telestration, because it's possible to telestrate and narrate, and that makes it even more powerful.
Yes, yes, that's a work in progress right now. Yeah, but I think your point well taken, and that's very important for teaching, of course. Yes.
Hi, do you have the capability to live stream or cast directly from the robot currently, or are you uploading and then rendering into 3D in the headset?
We haven't done the live streaming as yet. We are at the moment thinking of recording them and creating the tutorials, but maybe Mr. Aravind will be able to answer that question better from the technology point of view.
Yeah, thanks, Dr. Rooma. So we can do live. I mean, like the technology is available. We can do that with 4G technology. We don't even need 5G from the bandwidth perspective. This is quite possible. We've done this across different locations from UK to India, US to India as well. So that's clearly possible. Yeah. Sorry? How much? The headset cost? The headset cost, like on Amazon, you can buy for $200. So yeah, that's nothing. So we have a subscription plan which is separate from that.